Today, I am going to talk a little bit about some of the common aches and pains of the foot and ankle. And when I was trying to write this talk, I was just thinking about, foot pain. It's kind of one of these things that, everyone has foot pain, right? And, I know that if I'm standing on my feet for several hours operating, it hurts. So the tricky thing though is knowing when that is like okay because it's just you did too much and when that's not okay. So hopefully today I'll be able to share some good information and knowledge so that you can take that back and use it in your daily lives. So I don't have anything to disclose. So these are some of the places that I've had the privilege of training, but I wanted to highlight one thing. So I did my fellowship at New York, as Dr. Berry mentioned, the Hospital for Special Surgery. So one of the most memorable parts of that fellowship is being able to work with this man, Dr. Bill Hamilton. He was actually the orthopedic surgeon for the New York City Ballet, as well as the American Ballet Theater. And had the opportunity to be able to work with some of these amazing performers, artists, and really athletes and have a backstage view of what goes on in their lives and how difficult it is to be a dancer and really how hard they push themselves and their foot and ankle to be able to make things appear really beautiful on the stage. So after my training, I ended up in Chicago for about 7 to 8 years, and then came to UCSF. I joined in August of 2020, so I've been here for a little over a year, and I see patients in the city and also in San Mateo. So before I get into kind of the content of what we'll talk about tonight, I just wanted to address something that comes up every time I give a talk because when I tell other physicians, medical students, and that I'm an orthopedic foot and ankle specialist, often they'll say, oh, so you are a podiatrist, right? It's sort of assumed. And so there's actually a difference. And so, there are about 40,000 orthopedic surgeons in the United States, and we all belong to the American Academy of Orthopedic Surgeons. And so that's sort of our big professional group. And of those 40,000, you have some that are spine specialists, some that are hand specialists, some that are, sports specialists. And only about 2,000 of that 40,000 are actually foot and ankle specialists. So it's a very small percentage, and it's a very new subspecialty. And that accounts for why it's so small. So what that really means is that around the country, there's very few of us in practice. And so I did a quick Google search. So in the Bay Area, which according to Google has almost 8 million people, there are only 17 fellowship trained orthopedic foot and ankle specialists. However, there are many, many, many more podiatrists. And one of the things that is slightly different between orthopedic foot and ankle specialists and podiatrists is the breadth of medical training that we have. So I definitely do some very similar surgeries as my podiatry colleagues, such as bunions and hammer toes and ankles things. But orthopedic surgeons usually have much more breadth of medical training. So while I focus on the foot and ankle, I can also operate on the hips, on the knees, on the hand, on the foot, elbow, whatever. And so I think that makes us particularly appealing for patients because I can tell you I have so many patients who I see and their concern is that, well, I'm here for my foot pain, but do you think it's possible that my knees and my hips and maybe even my spine, that somehow is contributing or maybe triggered or created some of my foot issues? And so that allows us to have a bigger and broader approach to pain and pathology in the foot and ankle. So that's that makes us a little bit different. So tonight I'm going to cover a couple of topics from ankle sprains to really common cause of heel pain, plantar fasciitis, and I'll also talk about some causes of pain in the front of the foot, as well as an Achilles tendon issues. And these are all really, really common things that I see all the time. So before we get into that, I just want to go over some, terminology. So This portion in blue, I would call sort of the lower leg. Here in red is the ankle. The yellow circle is the heel, but it's also called the hind foot, so the back of the foot. And then the blue portion is the middle portion of your foot, oftentimes called the midfoot. And then the purple are your toes, and oftentimes we refer to that as the forefoot. And when we look at the foot and the ankle, the major bones is really the talus, which is the blue screen here, and then the fibula, which is the violet color, and then the yellow is the talus bone, and then the actual ankle joint is between the tibia and the talus, so between the blue and the yellow bone. And then further down is a bone called the heel bone, which is the calcaneus. And then just over that location, there's another joint. It's called the subtalar joint, often mistaken for, sometimes patients will say that's my ankle, but there's actually two joints in that location. So I'm going to talk about ankle sprains first because it's super common. And I took this slide from Dr. Berry's talk from last week, but just to go over and remind everyone what the difference between a strain and a sprain is. So a strain is essentially an injury around the muscle and tendon, whereas a sprain is an injury around the ligaments. So here you can see this is an ankle or foot, and then there's a ligament that there's a tear in. So when we say ankle sprains, we usually refer to injuries or tears in the actual ligaments. So an ankle sprain is commonly known as a rolled ankle. It's very frequently happens in sports, and according to the NIH, ankle sprains account for about 40% of all athletic injuries. And the way that it happens is, of course, your ankle almost like folds or buckles underneath you, and you can see in the center where there is the ligaments that shows ligaments that are healthy and intact. And then on the right hand side, you can see after the ankle kind of buckles underneath, you have some tears of some of those ligaments. The anterior talofibular ligament, otherwise known as the ATFL, just sounds very complicated. It's just a name for the most common ligament that's injured after an ankle sprain. So when I see patients in the office after an ankle sprain, this is the one place that almost every single patient has pain. When patients have an ankle sprain, they're usually running. Sometimes they're, landing from a jump, and they, land on another player's foot. And sometimes they're just walking on some uneven concrete on the sidewalk or just on a branch that they didn't really see. And then the ankle just kind of buckles underneath. They often will have a lot of swelling and pain almost immediately. Most patients say, I feel a lot of popping, clicking or snapping right when it happened. And then they can't put any weight on it. And then also most patients will say, right after the injury, I saw this big golf ball just start to get bigger and bigger on the outside of my ankle. And usually that's due to some bleeding from under the skin. And then here in these pictures, you can see that giant kind of golf ball has resolved, but now you see these black and blue marks, and that's kind of the bleeding that has settled, underneath the skin. So here's some top myth of ankle sprains that I've heard over my years in practice. So, I've heard some patients like, well, I didn't really come see anyone because it happens all the time. And, I thought I could just walk it off. And that is true some of the time. But, if you're someone that has recurrent ankle sprains, probably want to see someone and not just kind of, let it heal on its own. I've also heard patients say, well, the urgent care told me I'd be better in 2 to 3 weeks, and I'm not. And so what's going on? Is something not healing right? And so what I tell patients when I see them for ankle sprains, for routine ankle sprains, I tell them it will take you about 6 to 8 weeks to get almost fully better. Sometimes it can take up to 3 months to get fully better, and that is still normal. So that's a really important point, because lots of patients are like, oh no, I'm I'm 6 weeks out and I still have pain. And I would say, of course, after examining patients, that if everything looks okay, I would still say that's pretty normal. Another misconception is patients say, well, it hurts. And so I just stopped using it because it was hurting and I didn't want it to do any damage. And that definitely is true some of the time. But for ankle sprains in general, I always tell patients it's going to hurt. You're probably going to have some level of pain, even 2 months out from an ankle sprain. But that does not mean that you're going to stop moving, because if you stop moving, scar tissue sets in and everything gets really stiff. And that's way worse. So I always encourage patients, with an ankle sprain, after some rest, they really do start moving, even if there's a little bit of pain. And then the last thing that I hear most frequently for patients who have ankle sprains is they come in, they say the emergency room or their urgent care told me I need to have an MRI to see if I have a ligament injury. And the truth is, as I mentioned, if you remember back to the slide, an ankle sprain by definition is an injury of your ligaments. So we already know that you have some injury to your ligaments. We certainly do not need an MRI in that acute setting to see if you have it, because you do. But the good news is that almost all of the patients that have ankle sprains really do heal, and they do quite well. So when I see a patient in the office with an ankle sprain, I like to do x-rays, 3 views, complete x-rays of the ankle. And the reason is because a lot of times you just can't tell when patients come in and they roll their ankle, sprained their ankle a couple days ago. It's so puffy, it's so swollen, it's so tender. I can't tell if there is a fracture. So I always get x-rays. And then I always like patients to be standing on them if at all possible, just to put a little bit of pressure. That allows us to get more standard views of the ankle. And sometimes patients will say, well, I already got x-rays. And I always tell them, well, the x-rays are not standing. There's a lot of weird rotation that's in there. So we really can't see everything the way we'd like to. So we sometimes repeat them. So when you have an ankle sprain, the treatment of choice is, of course, RICE. And everyone knows that stands for rest, ice, compression, and elevation. And I really love this type of boot. I put my ankle sprains in this all the time. I feel that it really gives them a good supportive environment, to kind of allow patients to get around and walk. It allows them not to use crutches, which makes a huge difference, because I see patients hobbling in on crutches and they say, I can't use these crutches. Can I start walking on this? And, it makes their life so much easier when they have a boot that's really supportive for the ankle, but also, you can let them walk on it. So I usually have patients in a boot like that for about 2 weeks, and it really allows the ankle to rest and allows the ligaments to kind of start to scar down and to heal. And then usually after 2 weeks, I have patients start some formal physical therapy, and we focus on something called functional rehab. So functional rehab is a series of just exercises of, moving your ankle, of stretching, of also strengthening and building strength in those muscles, all to avoid the harmful effects of immobilization. And this is really important because I have definitely seen patients come in and there's 6 weeks, 7 weeks, almost 2 months, and they're still in the boot, and they tell me, well, I had pain, so I just thought I would just stay in the boot. And that's definitely not what we want to hear. When you have an ankle sprain, we have these goals, and we want to constantly be moving and hitting these goals. So you don't want to just kind of be sitting around in a boot for weeks and weeks and not really feel like you're getting better. I tell patients that by about 6 to 8 weeks, they are able to return to most full activities. However, this does not mean that you're pain-free. So this is really important to kind of set those expectations of saying you can do things, but it still might be painful, and that's normal. And maybe you're able to do things at the level that you were able to do before, and that's, again, very normal. My take-home point in these ankle sprains is really that if you or your friend or family member has had an ankle sprain, by 2 weeks, you should be able to get out of the boot and start having someone touch the ankle, move the ankle, and actually be participating fully in physical therapy. Or by about 4 weeks, you should be pretty good. Being able to get back to everything, you're not in the boot anymore. If you don't hit these goals, then that's when I think it's worthwhile to maybe talk to your primary care doctor and consider referral to a specialist. The good news though is that 97, 98% of patients with routine ankle sprains all get better, and very, very few don't get better. And even fewer might actually need some sort of surgery later on. So overall, it's really nothing to worry about. So I'm going to move on to heel pain. And this is something that I'm sure everyone has experienced at some point in their lives. I know I have. When I was pregnant, I had really bad heel pain, which ended up being plantar fasciitis. So what is plantar fasciitis? So the plantar fascia is this really thick structure on the bottom of our foot, and it's responsible for actually creating the arch in our foot. And when it is too tight, it'll actually cause a lot of pain. And sometimes it's like really sharp stabbing pain, like someone's poking you with a hot poker. And it's really common in runners. It's common in patients who are, 40s, 50s, to 60s. And then the heavier you are, the more likely you're going to have this type of heel pain. Currently, we don't know whether it, exactly what it's due to, whether it's inflammation or degeneration or a combination of both. We do know that when you have too much pressure on it, so when you're carrying a little bit more weight, it can actually cause this tissue, this red structure here, to start like tearing. So really small micro tears. And then those micro tears, then your body tries to heal by forming some scar tissue. And now you've got this kind of tight, thickened scar tissue on your heel that you walk on. So that certainly can contribute to the pain. So as I mentioned previously, you can see that in these pictures here that thick tissue in the bottom is called the plantar fascia. So just underneath it, or just one layer closer to the floor, is what we call the fat pad of the heel. And as you can see in this picture here, the fat pad has this like honeycomb compartment type of organization. And so there's fat lobules all compartmentalized in these little honeycomb structures. And the goal is that when you're putting pressure down on your heel, which we all do millions and millions of times every day or every week or month, the fat pad is there to actually cushion the area. And so when we're in our 40s and we start to get a little bit older, the fat actually starts to thin and they really atrophy. And that leads to a little bit less protection over the area. And then again, this is what can contribute to little small tears and thus some pain. So patients who have plantar fasciitis usually will present with very localized sharp pain in the bottom of the heel. They usually have one specific spot. So when I'm examining them, I'm pushing and I find this one spot. It makes them jump out of the their examining table. And so that's really common. And a really classic story that patients have with plantar fasciitis will say they have pain when they first get out of bed in the morning. So the first 10 to 15 steps is really bad. They're holding onto the wall, they're just trying to take pressure off of their heel. And then usually after about 15 steps, they definitely feel better. Also, sometimes I'll ask patients, when you go for a long drive and you're driving your car for 45 minutes, and when you get out of the car, do you have pain? And a lot of them will say, yes, that first 10 steps is really sharp. So that's really, really classic for plantar fasciitis. But, if you don't have those, it doesn't necessarily mean you don't have plantar fasciitis, but if you do, it's a good sign that you probably have this condition. The most important thing to remember is that you don't have any pain at night. So you go to sleep, you're able to get a good night's rest and wake up the next day with no pain that wakes you up. And then unfortunately, up to a third of these cases will actually have pain on both heels, which can be pretty debilitating. So there are some common causes of this condition. And so one of the causes, as I mentioned previously, was that this tissue is just so tight. So one of the other things is when you have a tight calf muscle or a tight Achilles, it can also lead to a really tight plantar fascia. And so that will make this, the tissue kind of start to tear a little bit because it's so tight. Also repetitive activities, so runners will have pain and have this condition because they're constantly putting repetitive pressure and stress on the bottom. And then also sometimes new activities, and it doesn't have to even be a high impact activity. You're just doing something new, and that can cause pain and plantar fasciitis as well. And then lastly, I have down here flat foot or fallen arches. So sometimes that the arches are a little bit flat, you actually will stretch this tissue on the bottom because, as I mentioned, this tissue is there to give you the arch. But if your arch is really kind of flattening, you're stretching this tight tissue, it will cause pain. One of the common misconceptions of this condition is this idea of this heel spur. So lots of patients will come in, they'll say, I have a heel spur. I think that's what's causing my pain. And so the heel spur you can see in this x-ray definitely looks pretty bad. It's large, it's pretty sharp, it looks painful. But the important thing to remember is that in patients who have heel pain due to plantar fasciitis, only half of them actually have a visible heel spur. The other half don't. The other half have perfectly normal looking bone. And so what that means is that the presence of this heel spur or this kind of sharp, jagged bone that appears very painful, that's actually not the cause of the pain. I've had patients come in and say, well, can you just shave off my bone spur? Because they think that's going to make me feel better. And we generally don't do that because the bone itself is not the cause. The cause is actually that tight tissue that attaches there. So how do we treat plantar fasciitis? The non-surgical or conservative treatments are definitely the mainstay of treatment. So that would include using, Advil, sometimes some stronger prescription anti-inflammatories can be really helpful. Also orthotics, which are kind of the cushions, right, that you can put in your shoe. And I always get asked, well, should I get custom orthotics or should I just, go to the drugstore and buy orthotics? So the answer is really, it doesn't really make a difference whether you spend, $500 on custom orthotics or kind of get the off-the-shelf ones. Because really, for most patients with this condition, we're really using that orthotic as a cushion for the heel. So you don't really need to spend lots of money to get that, cushion, right? You can get a pretty good one, at the drugstore, or oftentimes I refer a lot of patients that go on Amazon and buy them. Also, patients will ask me, well, my friend had this problem and they were told they should use this night splint. And I definitely did use this previously, but it's really difficult and uncomfortable to use because the splint, essentially you put it on at night and the whole idea is it kind of brings your foot back and kind of holds it there, right? Stretching your calf, stretching your Achilles, and it's really uncomfortable at night. And most patients say, well, I always put it on, but in the middle of the night, I end up just kicking it off, right? So I sometimes don't even bother mentioning this because it's so uncomfortable. And I feel like it's probably better to just get a good night's rest rather than try to fiddle with this thing that you'll probably just take off anyway. So the most important thing for plantar fasciitis is stretching. So it's a lot of physical therapy. So it's really stretching of the actual tissue itself, which is in the photos here. So actually stretching the plantar fascia. You can also roll a tennis ball, you can roll a golf ball, anything underneath the heel to really kind of stretch and massage the tissue. And then the other thing is stretching your calf muscles and your Achilles is really important as well. So ideally you would do the stretches of the plantar fascia plus your Achilles, your gastroc as well. And those are all gonna definitely make the pain better. And I think that the literature actually shows that if you just do simply this, 98% of patients will get better. So that's pretty good odds. So let's say you're someone that's done a lot of the therapy and you haven't gotten better. What do you do now? So usually when patients come in to see me, I will offer them a cortisone injection. Some patients will say, well, why can't you just do the injection now? I'm in a lot of pain. I'm here today. Can you just do it? And my answer is sure, I can definitely do it. But if you just rely on the cortisone injections alone, they're only good for a short-term relief. So you may only have relief for 2 weeks or 3 weeks. Whereas if you do it the other way of like doing the stretching and putting in the work of physical therapy, and then you come for the injections, you're much more likely to have much longer term relief. So I always recommend doing the therapy first, and then, if needed, a small cortisone injection. There's been some studies out there about Botox as well as PRP, which is kind of, the stem cell biologic type of injections to help plantar fasciitis. And I think some of the high level studies out there essentially show that there is really no difference of injecting these fancy medications or stem cell type of things compared to cortisone. They do equally well, but certainly there's room for further studies. And so because of this, I normally just do cortisone injections in the office. I have not done any stem cells, although we do have a biologic regenerative service at UCSF. So if you're interested, certainly that would be something we can refer you to. So surgery for plantar fasciitis is really, truly the very last resort. I try to do everything in my power to have patients get better and avoid surgery, because traditionally the open surgery, which is, as I mentioned, this tissue is too tight, right? So the surgery is actually just kind of making a little cut in this fascia to suddenly relax that tissue. So the results aren't really very good. And some say 50%. I mean, 50% is coin toss. Some say as high as 75%, but regardless, no matter how you look at it, if you're going to have surgery, you want to know that the odds are a little bit better than 50 to 70%. And so for this reason of a lot of failures and continued pain, we generally have not done a lot of these open releases. And one thing that has come out in the last maybe 5 or 7 years is a new procedure called the 10X procedure. So it's a more minimally invasive percutaneous procedure where it allows the fascia to be cut. And so this is a machine that we use, and it uses ultrasonic energy to remove the scar tissue without really damaging the good tissue, but it's done through a very, very tiny incision, maybe 5 millimeters, definitely less than a centimeter. And because it's minimally invasive, there is not as much scar tissue that forms in the area after the procedure. And this study done by Dr. Patel, but only on 12 patients, showed that 90% of patients at 3 months felt better. I would say in my own practice, I feel like it's probably not 90, it's maybe 80 or something, but it definitely patients feel better. And I'm always really careful to say that this isn't like this magic wand that you're going to get rid of all of your pain, but I would say to expect a good 70% pain relief is very reasonable with this procedure. Okay, so moving on to metatarsalgia. It's a very big word. So what is it? So it's a catch-all word. So when I say someone has metatarsalgia, it's not specifically a diagnosis. It's just saying that this patient has pain in the ball of their feet, so in the front of their foot. It could be due to bones, it could be due to tendons or anything. So it's a kind of a broad catch-all that can have any really cause to it. So when we talk about your foot, you can see this diagram of a foot, and there's lots of bones here. Each bone, or each ray, as we call it, or toe, has a metatarsal bone, has a proximal phalanx bone, and a distal, middle phalanx, distal phalanx. And the metatarsal, as I drew it out here in the red, they have this nice cascade. So the first metatarsal is the biggest bone. It's supposed to carry most of the weight. The second metatarsal is a little bit smaller and it's a little bit shorter. Third metatarsal, also a little bit smaller, a little bit shorter, and it has a nice cascade. So sometimes, based on our own anatomies, sometimes patients are born with, I'm sure, you know, when I look at my toes, like my second toe is a lot longer than my big toe, right? And so that type of a difference can certainly cause pain in the foot. And so bony anatomy can be a cause, but also all the nerves and blood vessels can be a cause of pain, as well as all the muscles and tendons, of which there are many on your foot, that all contribute to pain. So here's an x-ray of a patient who has this long second metatarsal. So you can see the red dot or the red line here, and that's where the second metatarsal is, but then the first is here. So this person has a much longer second metatarsal bone. So when they're walking and they're, push off, kind of toe off, they're going to be focusing all of their pressure on this area. So this person perhaps would be more likely to have pain on the ball of their feet over here, because this is a much longer bone than the first metatarsal. Other causes of pain in the ball of your foot, it can include a really tight Achilles, because the function of the Achilles is really to push the forefoot into the ground to kind of push you off into the next step. And so if the Achilles tendon is really, really tight, you're thinking when you're walking, you're really hitting the ball of your foot into the ground. You're kind of hitting it so hard. And so you're putting lots and lots of pressure there. And that is a really common cause of pain. And so sometimes the solution to pain in your foot is actually to stretch your Achilles, because if you stretch your Achilles, you won't have as much pressure on the ball of your foot and you'll have less pain. Another thing is when you have really tight Achilles and there's more and more pressure, that is one way you can develop a bunion, right? Because if you're pushing so hard, it's almost you're hitting the ball of your foot into the ground with every step you take, you're going to cause the bones to start shifting. So a bunion is here where you see this bone, which is the first metatarsal. It's really leaning out to the, in the wrong direction. And this is a pretty bad bunion. So again, for prevention of bunions, sometimes they'll say, well, one thing you could do is to start stretching your Achilles tendon. Other causes are shoe wear. I couldn't resist putting this x-ray in here because I am big shoe fan and I have lots of shoes. But as you can see, this is normal. So, when you're standing, the whole bottom of your foot is on the ground. That's what is the weight bearing portion. But when you wear your high heels, which is, 3 or 4 inches, you're basically focusing all of that stress on the bottom of the on the foot. And so obviously you can see that would cause pain in the bottom of your foot. Another cause is wearing shoes that are pretty narrow. So we call it, narrow toe box shoes. So again, you can see this person barefoot and you can see how wide their foot is, but then they wear shoes, women's shoes usually, and they're much more pointy. And so you can see it really compresses all the metatarsals, and that can be a very obvious reason for pain. Another cause for pain is the nerves. And so in this diagram, you can see the white are the bones, so the metatarsal, and then the yellow is the nerves. So they live right in between the metatarsals. And so when you wear shoes that are really tight, it kind of pushes the metatarsals together. And you can imagine the nerves really get squished between the metatarsals, and then that can cause pain. Sometimes it can cause numbness, tingling. And one common thing is sometimes patients will say, I keep thinking that I have something in my shoe, like there's pebbles or marbles in my shoe, and I keep taking my shoe off and there's nothing there. So that's a really common presentation. When patients say that, I always think of, okay, maybe they have a neuroma. So when you have a really tight Achilles, as I mentioned, we really encourage patients to start stretching. And so physical therapy is really important. When you have a patient who has a long second metatarsal, you can't change that about them. It's their anatomy. So oftentimes what we'll do is we'll use these pads, they're called metatarsal pads. We put them on the bottom of their foot. And the idea is that when you're standing, the pressure doesn't go into the ball of the foot, which is what's marked out in the marker here, but the pressure actually goes into this pad. Almost it transfers the pressure from the ball of the foot into almost the arch of the foot, and that can really give patients relief. And this is not something you wear forever, but temporarily while things get settled down, then you can go back to wearing regular shoes. And then lastly, with bunions, lots of patients have them, come in because of them, and the most common question that I hear asked is, I have bunions. When should I get them fixed? Or do I need to get them fixed? And it's, a difficult question, but one thing that I would say is that when you have bunions in general, they are progressive, which means once you get them, they will start to get worse. But they could take 20 years to get worse, or they can suddenly worsen in, 8 months. And that's where we don't really know. So we always want to be monitoring it and looking at your foot. One of the things that we can do as a conservative option for bunions is, of course, to wear wider shoes, right? Most patients who come in to see me with bunions, they've already tried that. Another thing that you can do is use these toe spacers. So between the first and second toe, that's really helpful. And then on the market, you can find all sorts of bunion splints or shoes or socks or whatever for bunions. And the reality is that none of these things work. I mean, you can certainly use them, but they probably is not going to make a difference in the long run because your bunion will get worse. But if it takes a long time to get worse, then great, you're lucky. You probably don't need to have surgery. But if it gets worse pretty quickly and it starts to actually limit your lifestyle, say you're very active and you're not doing a lot of things you want to do because your bunion hurts so much, that's when you decide that it is time for surgery. And when you need to have surgery, there's so many different procedures that can be done to fix the bunion. I think there's technically several hundred different procedures, but in general, there's a few ones that we use most of the time. So you can see in this before and after x-ray that the bunion has been fixed, but you can see the screws are over here. Whereas this next one, you can see again, bunion was fixed and the screws are further in this bone. So this is where obviously a specialist will be able to help make that decision as to which is the better option for you. And then if you have a neuroma, which I mentioned is kind of that nerve that's being pinched, most of the time we do treat this conservatively with anti-inflammatories, wider shoes. Corticosteroid injections work really well, and I definitely have done them. And for me, I feel they work extremely well to the point that I rarely have to do surgery on the neuromas. But the ones who don't work will often just go in there and cut out the nerve. I know it sounds kind of barbaric to remove the nerve, but sometimes it's the only solution. So you just have to remove the nerve. You can see the center picture is just a specimen of a nerve that was very swollen and inflamed that was removed. So I'm going to move on to Achilles tendonitis, which is the last topic. And it's, again, super common and see this all the time, regardless of how young or old you are. I see it almost daily. So the Achilles tendon is one of the largest tendon in your body, and it is in the back of your leg, and it inserts on the bone, which is called the calcaneus, so essentially the heel bone. The Achilles tendon has a small area that doesn't have very good blood supply, so we call it the watershed area, and that's about maybe 6 centimeters up from where it goes into your heel. And that's also why when patients tear their Achilles, they almost always tear at that section because that just doesn't have as much blood supply. So it's always torn there. The Achilles tendon, because it is the biggest tendon in your body, it does encounter stresses that are 6 to 10 times your body weight. So it encounters a tremendous amount of stress in the area. So that when you have tendonitis, which is just an inflammation and sometimes very small micro tears of the tendon, it is a really common cause of pain in the back of the heel. And when you have Achilles tendonitis, you can have something called insertional tendonitis, which is in the picture on the right, where you can see this bump right at the bottom where the heel is. And then you can have non-insertional tendonitis, which is tendonitis further up along the path of the tendon itself. And both of these oftentimes can be due to overuse, and both are very painful. Sometimes they're very swollen. If you push in the area, it's very painful. And the treatment for both of these is actually mostly conservative treatment. So putting a lot of ice on there, doing anti-inflammatories like Advil, Motrin, or a prescription anti-inflammatory, and then most importantly, physical therapy. And when I say that, I specifically mean stretching. So we really want to stretch the tendon, because the reason why anyone really ever gets Achilles tendonitis is because the tendon is simply too tight. And so it's almost a little bit like plantar fasciitis that we talked about, because it's two things that are just too tight in your body and cause pain. So if you stretch it, almost everyone gets better. So that's the most important thing to remember for Achilles tendonitis. It's physical therapy, stretching, stretching, stretching. Another thing we can use that's really simple are these heel lifts in the picture here. And these are just, a couple of bucks. You buy them at the drugstore and you just put them in your shoe. And what it does is it takes that tension off of a really tight Achilles, because you're essentially raising your foot by about 1 centimeter. And something as small as that can really take that tension off of a tight Achilles and give you some good pain relief temporarily. And then for patients who have really bad tendonitis where they're hobbling around, they can't, even walk a short distance, I often will put patients into a cam walker, that big black boot that I use for tendon or for ankle sprains. I'll use that for about 7 to 10 days, and it really helps the tendon to kind of rest, to settle down, and a lot of their pain does go away. So aside from Achilles tendonitis, we also can have Achilles tendon ruptures, right? So these are different. So it's not just tendonitis, not just an inflammation of the tendon, but an actual tear of the tendon. And so these tendons tears are usually the highest amongst maybe 40, 50s patients, and usually they occur in men. And then they usually are patients who we would call sort of like the weekend warrior, right? Who are, they work jobs, but, on the weekend, they're very active. They play basketball, they play soccer or tennis. And, it's when they're playing, they feel something pop or give. And that's usually the very classic story of an Achilles tendon rupture. Now, there are some risk factors for Achilles tendon ruptures. So these are a couple of ones to be aware of. So one is the use of steroids. So whether it's oral steroids or injected steroids, steroids are great for taking away inflammation, but they're not good for tendons. They can cause tendons to really weaken, and they can tear. Another really common thing that can cause Achilles to become painful is the use of antibiotics. So this class of antibiotics called fluoroquinolones, when you use them, they can be really harmful to tendons. Most of the time, medications like Cipro or Levaquin, those are really common fluoroquinolones that are used for like a urinary tract infection. Usually those are the kind of culprits. And I definitely would say that many times when I see patients in the office who have Achilles problems because of this, they knew about it because their doctor kind of warned them, like when you take this, this might have some side effects with your tendons. So that class of medication can cause tendonitis. And then other things that can cause it are like fallen arches. And you can see in this diagram or in this photo here in the left-hand side. So when your arch falls, you have what we call pronation. So you can see those red arrows. And so there's a kink in your Achilles tendon. So when you have that kink and then the tendon is essentially stretched a little bit more, you're more likely to have some sort of tendinitis or pain along the tendon. What's really interesting for most patients who have ruptures, though, is that they've never, almost every patient I've had who had a rupture, no one has ever said, oh, I have had a history of tendinitis. There are patients who always say, I have never had any problems with my Achilles. I was just playing tennis and it just popped. So that's pretty interesting to note. So that patients who rupture actually don't have a history of previous injury. So when you have a potential Achilles tendon rupture, which means the tendon completely tears, the most common thing we do is this Thompson test. Basically, we squeeze the calf, and then in an intact Achilles, your foot will kind of go up, and then if the tendon is torn, your foot won't move. But I think one of the most underappreciated techniques to diagnose an Achilles is actually just looking at the patient. So I have the patient lie down flat on their stomach and I just look, and this is what I see. And so the ankle on the right hand side is the intact Achilles, because you can actually see the tendon, but on the left hand side you can see like it's just kind of puffy and swollen, right? There's no obvious tendon there, so that's the one that's torn. And then you can also tell by looking at the resting tone, whereas on the right hand side that the foot is a little bit more pointed, and then on the left hand it's not really pointed, the foot's just kind of hanging at a 90-degree angle. Also, if you feel a gap, that obviously tells you that there's a tear. But I would say that it's difficult for patients to feel their own gap because if they push pretty hard and it can cause pain. So it's something that I usually do in the office. And then I haven't read here that an MRI or an ultrasound is usually not necessary. And I say this because I have lots of patients come in with Achilles tendon ruptures who say, oh, well, don't I need an MRI? And again, you could get one, but this is a diagnosis that we can make based on clinical exam. It should be very obvious. And I don't need an MRI or ultrasound to tell me that. So that's usually, what I tell patients. The history for these Achilles tendon ruptures is that patients will usually say, I was playing some sort of sport. I was standing there and I thought I got kicked, or I heard a pop and I thought someone hit me in the back of the leg. And I look around and no one is around me. No one's even near me, and everyone's on the other side of the court. So that's a really common thing. Patients can still walk. They're sort of limping, but they're still able to walk. And then the other thing is that, after a week or so, your pain really goes away. And, sometimes patients can be fooled into thinking, oh, I'm better. And I've definitely seen patients and even, other internists who, isn't so familiar with Achilles, perhaps, and they tell their patients, I think your Achilles is fine, like you can walk, you don't even need pain anymore. And that's always, you definitely, if you think there's something wrong, I would say that you're your own best advocate. You want to kind of push and maybe just see a specialist, because the worst thing is we see a patient months out and I see that I'm like, oh, goodness, you have Achilles rupture and we didn't even know about it. So here's, again, what I was just talking about, some pitfalls of clinical diagnosis is that, sometimes that defect, that gap can be masked by some bleeding. So there's bleeding and there's some initial scar tissue. So when you feel it, you feel like you can feel the whole length of the Achilles, but in fact, there's actually a tear. And then also pushing off, being able to kind of push to walk in the next step. Sometimes, that can be misleading, but the fact is the Achilles tendon is only one tendon whose function is to push off. And in your foot and your leg, there's lots of other tendons who can do the same thing. So if you're kind of using push off and being able to walk as the criteria for Achilles tendon ruptures, you'll probably miss a couple. So again, definitely, if there's any doubt, you think it might be your Achilles, you'll want to probably see a specialist. For Achilles tendon rupture treatment options, there's really no consensus. So what I tell my patients is when I see them, I say, The bad news is that you have an Achilles rupture, but the good news is no matter which option you choose, whether it's surgery or no surgery, you are going to heal. But the difference in the healing is that with surgery, your tendon is reapproximated back to what was the normal anatomic length. But without surgery, it will heal, but maybe it'll heal a centimeter or 2 centimeters longer. And the way to make that decision is really the lifestyle of the patient. So if you are someone who is very active and it is not okay to be weak to push off and have some weakness or to have a little limp, then you might want to consider having surgery. But if you're a little bit older and you're say, I'm pretty sedentary, I'm not running, I'm not playing basketball anymore, I'm okay with a little bit of weakness, then it might be better to just leave it alone and treat it without surgery. So a couple of things that are contraindications to surgery, meaning like maybe you want to have surgery, but I would say, we probably should not do surgery. So that would include patients who have diabetes, especially if they're poorly controlled. Usually those patients have neuropathy, so they're really not able to feel very much. And then also someone who's immune compromised. So let's say you recently had chemo or something for cancer. So these are patients who are just going to have a little bit more trouble healing. And so we definitely maybe want to really think about whether surgery is the right option. Because the number one complication of Achilles tendon surgery is wound, meaning the incision that we make to repair these tendons, they don't heal. And that can happen in as high as 20% of patients. And so then if you add in, if you have diabetes or if you're immune compromised, it can be even higher. So we definitely don't want to have a complication in surgery. Other things that are really important is if you have circulation problems, right? You need good blood flow and circulation to actually heal. And so if you don't have good circulation, the likelihood of you being able to heal the wound and heal the tendon are low. So that would be someone who we might want to think about whether or not they truly need surgery. And then lastly, I have tobacco usage, so smoking. So smoking is not ideal because the nicotine really constricts your blood vessel. So if you think about the size of the blood vessels in your body, your foot and ankle is the furthest away from your heart. So by the time those blood vessels make it down to your foot or ankle, they're usually the smallest in your body. And so if you add nicotine, which then constricts the blood vessels, then you have even less blood flow. So again, it would lead to higher rates of complication and wound healing. So while there's no consensus as to whether you should treat Achilles tendon ruptures with surgery or without surgery, there are some things that we can all agree on. One is that it is a long recovery. So whether you have surgery for your Achilles or you do not have surgery for your Achilles and you treat it conservatively, it'll take you a good year to really fully recover. Also, regardless of whether surgery or no surgery, you are pretty much in a boot, one of the black boots, for about 3 months. And that's because you're always constantly the first 3 months trying to protect that site where it was torn. And then also, we know that surgery definitely decreases the risk of a re-rupture, but that's at the risk of a wound problem. So there's pros and cons. So it's definitely helpful to kind of make that decision with your specialist. And so some of my take-home points for today is really just when you are, seeing your primary care doctor or specialist, I feel like it's most important to be able to localize the pain, because when patients come in, they're able to tell me it hurts here immediately based on where they're telling me. I can think of a couple of diagnoses that I'm thinking about in my brain. Whereas if a patient says, oh, it's painful everywhere, it's hard for me to kind of hone down on what I think is really wrong. Of course, take a look at shoe wear, right? I always tell patients, because I'm a big shoe person, I say, like you can do most things in moderation, including shoes, right? So there are some fashionable shoes that are great, but you wear them for a short period of time and then go back to, wider shoes. Also, you want to keep in mind some of the other medical conditions that you might have. So diabetes, heart disease, circulation, because all of that can contribute to some issues with the foot. And then lastly, and probably the most important when we think about issues with your foot and ankle is what is your lifestyle? Are you a pretty active person, pretty sedentary person? Because that is probably the most important thing that helps us to make decisions as to how we treat certain pathologies. And that's it. So thank you very much.
Great talk, Dr. Chen. Thank you so much. I learned a ton, so that's good. Now, so I'm going to jump through these questions a little bit, and I'm not necessarily going to go in orders, but I'll try to get back to everybody. So the first one is kind of related to the tendon issues that you were just talking about with the Achilles. In relation to the fluoroquinolones, do we know why that happens or why that association is what it is? And then what's kind of the time frame that most people have to worry about after taking it when they might be in trouble for a tendon issue?
Yeah, no, good question. I don't know the actual mechanism of why this specific class of antibiotics, like how that actually works in terms of damaging the tendon. So I can look that up, but I don't know how that really works. But in terms of the timing, I would say that, once you're on these medications, and I would say most of the internists or people prescribe these medications because that's such a well-known side effect, patients are told, hey, watch out for this. And I would say probably, within, anytime 6 weeks after, from the time you take your Cipro into about 6 weeks, you're, looking and, kind of monitoring your tendon, your Achilles tendon. But the good news is that usually, let's say you're on a long course of Cipro and you're on it, when you stop, when that, medication flushes out of your system, usually the tendon pain also kind of starts to go away. But I have definitely seen patients who are, 6 months later, they have this and they're always asking, well, do you think this could have been related to my antibiotic? And I don't know the answer to that question. But yeah.
But it's typically in a short term afterwards.
That is correct. Yeah.
Great. Another question is related to kind of ankle sprains. And are there specific footwear or exercises that people can do to prevent them? And then kind of a side question to that is, if someone's quote unquote prone to ankle sprains, what would you recommend they do if they still want to maintain a high activity level?
Yeah, great question. So in terms of someone who, is prone to ankle sprains, you really want to look at what makes them prone to it, right? Is it because they've had so many and now their ligaments are really loose and that's why they're rolling their ankles all the time? Is it because the muscles, which are called the peroneal tendons or muscles, and whose main function is for ankle stability, is it because those are really weak and they just need a little bit of physical therapy to strengthen them? Or is it because their whole foot structure is one where they have a really high arch? Because patients who have really high arches tend to have a little bit more unstable ankles and they can frequently roll them. So I just mentioned 3 things that could contribute to recurrent ankle sprains. So I would say in that case that would be a great patient that I would see, and I would kind of try to tease that out and say, what is it? And obviously if it was just weakness of the peroneal muscles and tendons, I would have the patient go to therapy. If it was just the structure and shape of the foot, there are customized orthotics that would really help kind of balance that high arch out. And this is the one instance where I actually feel like custom orthotics are really helpful and it's worth spending $500 for them. Most people do not need it, but this is a case where it might be. And then the first part of the question I think was, are there specific exercises, right? So as I mentioned, the peroneal tendons they're the tendons on the outer side of your ankle, and their primary function is for ankle stability. So there are, you could probably Google them, but there's lots of exercises targeted specifically for those tendons to make them nice and strong. And that's what, someone can do on their own.
Awesome. And we're going to try not to get too specific with personalized questions, but I'll kind of turn some of these into more generalized questions. You talked a little bit about plantar fasciitis and kind of that band of tissue on the bottom. Are there other things that can cause kind of like lumps or kind of balls of tissue in that area? And what's kind of on your differential if someone says they have kind of just like a lump in the middle of that kind of arch portion of their foot?
Yeah, absolutely. It's a good question. Something that I see all the time as well. So the plantar fascia is that really thick structure on the arch of the foot. And so sometimes you can actually have a little growth on it, and it's what we call plantar fibroma. So basically it's just a little ball of scar tissue. And that will present as a lump or a bump that you'll literally run your hand down along the arch of your foot, and you can feel this little bump, and you're like, what is this thing? The good news is that's totally benign. It's very, very common. Lots of patients have it, and when you have it, it's very slow growing. Like it, might really not do anything for 10 years, and it's there. So that would be one thing. Other things that can contribute to the pain in the heel. I mean, there are nerves in the bottom there, and sometimes you can have this nerve it sort of mimics, heel pain, plantar fasciitis, but it's actually this nerve that's like really pinched between the muscles in the heel. So oftentimes, we call it like Baxter's nerve. You might Google that and read about that. But yeah, that would be another cause of heel pain.
Now, what may cause, and this is kind of like a trio of questions, but number one, can you get arthritis in your feet? I think I know the answer to that one. Number two, as you get older, what might make our foot get larger? Okay. And number three, why do our feet crack or our ankles crack as we kind of move them around?
So you can definitely get arthritis, right? Anywhere you have a joint, which is two bones and cartilage in the middle, you wear out the cartilage and you have arthritis, right? You can get them anywhere. You can get them in your neck. There's tons of bones and small little joints in your foot. So definitely arthritis, really, really common. One of the most common things that I see. So that's one. What was the second part?
Why does our foot get bigger as we get older?
Oh, right.
What's causing that?
Yes. So shapes of our feet will change as we age. And so a common structural cause is, you'll see patients over time, their arch will start to fall. So sometimes as the arch kind of falls, like the foot kind of like it has, it turns. And so, sometimes patients will perceive like, oh, like my foot's bigger, I have to get a wider shoe. That's one thing. Other things are just, especially for women, right? I know that my feet really widen after I had my kids, with childbirth. The inner metatarsal ligaments, the ligaments that hold the metatarsals together, they kind of stretch, and then all of a sudden your foot's just like a lot wider than it used to be. So those are really common causes. And, I would say that if you're noticing something kind of pretty dramatic or other people are noticing that, and sometimes, if it's us, we sometimes don't notice, but if like people around you, it's like, oh, why does your foot turn in like that? Usually that's something to look at, right? And maybe to see a specialist. And then
what's the cracking? What's the cracking in our foot? Is that something to be worried about? What is that?
That's right. Yeah. So I tell patients, any time or anywhere in your body where you have joints which are moving, right? And then you have tendons and ligaments kind of gliding on top of them, it is very normal to have clicking, cracking, snapping, whatever sound you feel like they make. Totally normal. Most of the time, those sounds, they're not painful. It's just like cracking your knuckle. They're fine. The only time we worry about clicking, snapping, or whatever is when it's really painful. Like every single time I feel this clicking, snapping, it hurts me. Or like something just feels off, and I have to bend the toe down. Those things we definitely want to investigate further. But in general, any sort of sounds or you might hear, and if it's not painful, it is nothing to worry about.
Great. What might be sorry, we're jumping around a little bit, but what might be a cause of kind of, and I think you talked about this a little bit in your talk, but maybe going through maybe some of the other things that you think about when someone's having numbness kind of at the ball of their foot, and what some treatments might be for that kind of forefoot numbness.
Right. Yeah. So I would say if you come in and you tell me that I have numbness, one of the first things that I will think about is the potential neuroma, right? The little nerve that gets pushed, pinched in between the metatarsal heads. But usually that's very specific. You'll be able to say, here, where my finger is, that is where I have numbness. But if it's more diffuse and you say, I can't put one finger on it, it's everywhere on my foot, then we think of other nerve impingements. So one thing could be, if you have diabetes, you might have neuropathy, which means there's little tiny nerves that innervate the very, kind of distal parts of your foot. They don't work very well, or they're really hyperactive. And so they lead to this like numb feeling. So that could be one thing. There are other nerve impingements. So for instance, tarsal tunnel. So I'm sure everyone has heard of carpal tunnel, right? That's this in your hand. So you have a very similar nerve that goes down in the ankle. And then if that nerve gets pinched, you'll have a certain distribution where things are numb. So those are kind of the things that I think about.
The treatment, I'm guessing, depends on what the...
Right, exactly. Yeah. So the treatment depends on what it is. So if it's usually a neuropathy, then that may be a more global, like looking at, we may talk to your internist and say, why is this patient having neuropathy? And usually I would say there's no surgery for neuropathy, right? Because it's just the nerves are really hyperactive. So some of it is medical treatment. If it is a very specific nerve that's pinched, oftentimes we can do a decompression. So exactly like carpal tunnel release, where you open up the thick tissue overlying the the nerve and the wrist. We can do a very similar surgery in the ankle, and we can release that really thickened covering of that nerve, and things start to feel better.
I think there's one point maybe that, difference between the podiatrist and the more global orthopedic approach to things is kind of working your way up from the foot and not necessarily just focusing on the foot, but really trying to figure out what the issue at hand is.
Mm-hmm.
And then also I just add on to that, neuropathy is something that sometimes there is not a specific cause for it. Some patients can just get neuropathy, and it's not that you have diabetes, it's not that you have anything, it's just kind of, you just get neuropathy. And so that's something that can happen as well.
Mm-hmm.
Okay. Do you have, or are you willing to give any recommendations for kind of decent footwear, just for preventing foot pain and injuries? Is there a specific, I don't know if you want to say brands, but maybe just like if you're looking for a reasonably priced shoe, what are your recommendations to patients?
So in general, right, you want to look for a shoe that has a pretty wide toe box, right? So you don't want a shoe that's pretty narrow where it's like squeezing all your toes together, because that's a perfect way to actually cause pain. So something that's a little bit wider. You also want to look at the sole of the shoe. So I know that a few years ago, there was this craze of like minimal shoes, right? So I saw a lot of runners wearing those shoes that have the little, like the rubber shoes that have like the toes like individual, and they were really lightweight, and they were running, and everyone's getting stress fractures. So you want something that's really kind of nice and well padded, and with a nice footbed, so something that's going to cushion everything. And then ideally, I like shoes, whether they're dress shoes or gym shoes, that have straps on them, right? That like strap itself onto your foot, because shoes like flip-flops or sandals that, you just kind of slide your foot in and walk around, you may not realize it, but your foot actually has to work a lot harder to grip that shoe and to keep it on your foot. So flip-flops are usually kind of like the worst, the ones with the little thong like between the big toe and the second toe. So I always recommend wide toe box, good supportive sole. And I feel like the thicker the better because it's more supportive and more cushioned. So it will kind of prevent a lot of the things like plantar fasciitis, like I talked about, where it's because you don't have enough of your own fat there. So you really have to cushion it. And then shoes that have some sort of strap that goes, that can kind of keep itself on your foot instead of like easily falling off. So those are some of the common qualities I would say in good shoe wear.
And then kind of in a similar kind of thing for that, in an urban setting, or if you're trying to just get your steps in, what are good surfaces and what are bad surfaces? And in particular, what about like the beach versus like rubber tracks versus grass versus concrete versus what?
Right. Yeah. That's actually a great question. So, what I would say is in a young, or not even young, in a healthy person that has no foot and ankle issues, no injuries or anything. I mean, they can tolerate any of those, right? But what I would say is the more uneven the surfaces are, the harder it is on your foot and ankle. So if you are someone who kind of frequently rolls your ankle or occasionally does, and sometimes you could just be walking down the street and there was nothing, you didn't step on anything and your ankle just buckles, then walking on an uneven surface will be really difficult because you're more likely, or you're more prone to maybe having an injury. So, for those patients, maybe sticking to kind of flat surfaces where your foot doesn't have to adjust to that uneven quality. And obviously, it may be a good idea to, seek the help of a physical therapist, because if you feel like walking on uneven surfaces is really difficult, or sometimes patients will say, when I'm going hiking, I'm walking on, just terrain, I get really sore, like on the outer side of my ankle. I hear that all the time. And that's because you're working those peroneal tendons so hard. And so again, that might mean that it's a little bit weak. And so going to physical therapist will be particularly helpful. But I don't have any specific recommendations in terms of, harder concrete versus kind of a rubber surface. I think obviously in a rubber surface, there's less impact, right? On a hard concrete floor, all of that impact is really, harsh and goes right into your foot. Whereas on a softer turf, there's more of a cushion.
I think that kind of answers one of the other questions, which was when you're jumping or walking, is most of the force going through the bones, or is it going through the soft tissues around the bones?
I would say both, but definitely both.
Yeah, both. Kind of the weight has to go through the bones, but there's counter forces going through the tendons that are keeping you from falling over, I guess would be the best way to put it. This kind of goes with, so say if you're prone to injuries around the foot, does wearing like an ankle brace or high top shoes or very tight shoes that are kind of giving you a ton of support, is that going to make you more prone to those injuries when you're not wearing the tissues? Or are you going to start getting weak, or is it okay to use kind of supportive devices?
Yeah, no, actually, that's another great question, because I have these are questions I feel like I have with my patients all the time. So my view on braces, ankle braces, high top shoes, all these types of things is that they are great, but they should be used in the short term. So it shouldn't be like, oh, I rolled my ankle, and so now every time I play basketball, I have to wear my ankle brace. That's not our goal here, right? Because in some ways, the more you wear these things, it's an external support. Your brain or your body kind of knows there's something there. So I think that in the long run, it will make some of those muscles whose job it is to actually provide ankle stability a little bit weaker. So I usually tell my patients that you should not wear braces in the long term, just maybe for a month or so. And if you feel you can't get off of the brace, then, we definitely need to be more aggressive about rehab and getting those muscles to be stronger. A good analogy that I heard in one of the other talks, I think at a foot and ankle meeting, was one of the speakers that said, if you were in a car accident and you got whiplash, and you had some neck injury, and you wore one of those neck foam braces, right? When people see you, they're like, okay, yes, we get it. But if someone wears that for like a year straight because they had this injury, you would think there was something weird, right? It's like you want those neck muscles to start working. So I liken that to the brace of the ankle, is that you don't want to use the brace constantly. It's just for a short term.
And to the person's direct question, it was kind of like if you're wearing a very kind of tight, supportive work boot all day long, is that going to make you weaker? And I would kind of say, maybe if you don't mind, like, I think there's a little bit of cross training to everything, right? You want to kind of mix and match it up. You don't want to be doing the same thing all the time, and you want to keep all the muscles kind of on their toes, so to speak. So maybe yes, in terms of her question, if you have a super supportive high top shoe, that maybe those ankle muscles aren't getting worked as much, but when you're off the job wearing something else, you're probably getting enough as long as you're in an active, healthy lifestyle.
Yeah, totally agree.
Okay, just a couple more. What you didn't really talk too much about kind of bumps and things on the top of your foot. What might be something that people experience kind of above the arch, kind of midfoot bumps? What could those be from?
Yeah, again, great question. So a common cause of bumps on the top of the foot are actually bone spurs, right? What patients perceive like, oh, I have this bump and I don't know what it is. When I tell them I get an X-ray, it's a bone spur, they're kind of like, really? This is a bone spur? And yes, because the thing is, if you look at your own feet, the top of your feet is there's not a lot of soft tissue coverage. It's not like our hips, where there's like a big muscle, there, right? Or even the shoulder, a big muscle. So the top of your foot is really just, bone. There's some tendons that are under the skin, and then there's your skin, and that's it. So any bumps on your bone that you might form from wear and tear or whatever, you're going to see that as bumps. So that's one common thing. Another common thing is ganglion cysts, right? So cysts are basically these fluid-filled pouches, totally benign. They usually arise from a tendon, because the tendon has a sheath, which is a tunnel that the tendon runs through. And then there's usually lubricating fluid that lubricates the tendon. So sometimes next to that area, you can have a little pocket of this excess fluid. And then same thing if it's next to a joint, because joints have lubricating fluid, you can have this pocket of fluid from the joint. And so that can create a ganglion cyst. I would say that those are probably some of the two most common causes of, lumps and bumps, and both are really quite benign, but, definitely important to, if you have it, sometimes it gives you a little peace of mind to know what it's from. So.
Is barefoot walking one of the risks to getting some of these lumps and bumps, or arthritis in the foot, or what's your take on barefoot walking?
Barefoot, I think barefoot walking is fine. The one patient population that I think should avoid that are those patients who are neuropathic, right? So they just don't feel as well, right? And most of those patients will have diabetes, but I do see a good number of patients who have neuropathy and they don't feel as well, but it's sort of like idiopathic, meaning there's just no medical explanation on why they have it, yet they have it. So if you can't feel your foot very well, walking barefoot is pretty dangerous, because if you step on something, you're just not going to feel it. So that would be the one group that I would say barefoot walking is probably not great.
In your time kind of working with the ballet, what were kind of the most common injuries that you saw? We'll start with that one.
Okay. Yeah, no, absolutely. So one of the most common things that so bunions are really common, right? So in a lot of the ballerinas, right, or really anyone, right, they go on point. And I should have actually had an X-ray of what your foot looks like when you're in point shoes, because it's literally just, standing on the tips of your toes. So that really causes a lot of deformities in your butt, in your big toe. So the dancers can, get bunions. They also get hammer toes, right? Because they're toes that start to get really curled and crooked. So those are common. And really the treatment while those dancers are dancing and they have a dancing career is to just live with it, right? So every single dancer I saw had their little bag of pads, tapes, band-aids, cushions, really everything, right? Because they're like, they know that, or have been told that, if they fix their bunion or the toes, I mean, number one, if they go back to dancing, it's just going to come back, but also it can be career ending. Like if their feet have changed because you've corrected it, they can't dance the way that they did previously. So a lot of forefoot problems. And then a really common problem for dancers, especially ballet dancers, is this condition called an os trigonum. So basically I didn't talk about it, but behind your ankle is this area where sometimes you can have a little extra bone. And then almost all of us, because we're not ballet dancers, we never even know it. It's just an extra bone that's there. It's no big deal. But if you're a ballet dancer and you have to go on point, that little bone can get pushed between like the tibia. It basically gets crunched a little bit in the back of the ankle. And that actually sometimes prevents their toes or their ankles from being totally on point and being perfectly, vertical. And so we actually had lots of dancers who ended up getting that bone removed. So we, it's an os trigonum excision, and recovery is pretty quick for that, but it'll allow the ballerina to get a better form especially when they go on point. So those are some of the common things, but it's really fascinating. Also just to see the mindset of these dancers, right? Because I've never, I've been to the ballet, but you actually talk to them and it is their life.
And then, okay, last one. So, and then this is kind of on a totally different subject, something you haven't talked about yet, but say you've had one of these surgeries and you have hardware in your foot. Does it need to come out? Are there complications to leaving screws or plates or sutures in the foot?
Yep. Yeah. So if the hardware is placed appropriately, which means it's not too long, it's not like part of it is in the joint. If it's kind of where it should be, I would say most of the time, no reason to take them out. I mean, it is correct. You don't need them there, right? After they've done their job of holding your foot or ankle together, after it's all healed, it's just extraneous. So certainly they can be removed, but it is an actual surgery. So if it's not bothering you, then I would say leave it alone. But on the other hand, if you have pain in that area and you're told that, well, it's all healed, but it's still very painful, or sometimes patients will say, I can feel the screw, like the bump on, where I had surgery. Also, I have patients who are big skiers, right? So those ski boots are super, super tight, so hard to get your foot into it. So especially if they have some hardware and they can feel it when they're in a really tight ski boot, it really hurts them because that boot's pushing down so hard. So those are some good reasons to potentially get them out. But if none of that is you and you just happen to have some hardware and feels pretty good, I would say no reason to try to take them out.
Awesome. Thank you everyone for coming. That was really good. Thank you so much, Dr. Chen. That was great.